Okay, let's unpack this. We're tackling a huge problem today. Why do our oxygen carriers, our red blood cells, sometimes die way too soon?
Mm.
We are diving deep into hemolytic anemias, which, this is a fundamental challenge to the body's entire oxygen delivery system.
It's truly a cornerstone of hematology. Our source material really emphasizes this. To get to grips with any of the complex blood disorders, you just have to understand hemolysis, this premature destruction of red cells.
Absolutely.
And this deep dive is so crucial because it forces you to bridge that basic red cell physiology with some incredibly complex clinical pictures.
Right. And for every patient, we're really asking, three core questions. First, what's the mechanism? Is the defect like intrinsic to the cell itself, like bad?
No, is it extrinsic, something from the outside attacking it?
Exactly. And second, where is this destruction happening? Is it inside the blood vessel intravascular, or is it being filtered out by the body's cleanup crew?
Extravascular, yeah.
And that leads to the third question, which is really our mission for you, the learner. Our goal is to systematically break this whole complex field down.
We're going to start with the normal life cycle, move through the pathology, and give you all the clinical, the conceptual, and the diagnostic takeaways you need.
So you can understand these conditions completely without just, getting overwhelmed by the sheer volume of facts.
That's the plan.
So before we can even talk about things going wrong, we have to set the baseline. What's normal?
Mm.
When everything's working perfectly, what's the lifespan of a red blood cell and how is it taken offline?
The normal lifespan is remarkably consistent. It's a mean of 120 days. And the process of normal red cell destruction is just incredibly well controlled and efficient.
And it happens almost entirely extravascularly, right?
Almost entirely.
So it's not just dissolving in the plasma.
Yeah.
Where is this physiological retirement party held?
It's handled by the reticuloendothelial system, the RE system. So we're talking about these specialized macrophages, which are located primarily in the bone marrow, the liver, and really importantly, the spleen.
And these macrophages are just constantly patrolling.
Constantly.
And what triggers a macrophage to say, okay, this cell is done?
It's a process we call senescence. The red cell, as you know, it's unique. It ejected its nucleus when it was maturing.
So it can't make new parts.
Exactly. It's an end-stage cell, a machine that can't print new replacement parts. It can't synthesize new RNA or proteins. So over those 120 days, its crucial internal enzymes degrade, the structural proteins degrade.
And the cell itself changes.
The cell becomes stiffer and, crucially, less deformable. So when these age-stiff cells try to navigate the really tight microcirculation, particularly these tiny little passages in the spleen called the cords of Billroth, they just can't make the tight turns.
And the macrophages recognize them.
The macrophages recognize these non-viable, stiff, old cells, capture them, and just remove them from circulation. It's very efficient.
That structural change is the ultimate trigger. Okay, so once the macrophage has engulfed the cell, it starts breaking down the hemoglobin. We need to trace this pathway exactly because this is the foundation for all the clinical signs we'll see later, like jaundice.
Yes.
Let's start with the Haem molecule. What are the three resulting components?
You've got iron, protoporphyrin, and the globin chains. Let's follow the iron first.
Okay.
So inside the macrophage, the iron is liberated from the Haem molecule. It's then bound to this plasma protein called transferrin, and it recirculates with incredible efficiency.
And where does it go?
Almost all of that liberated iron goes right back to the bone marrow erythroblasts to synthesize new hemoglobin. It's a beautiful, essential, closed-loop recycling system.
So the iron recycling is exceptionally fast. What about that complex ring structure, the protoporphyrin?
Ah, the protoporphyrin ring. That's what gives us the clinically visible byproducts. It's broken down first into biliverdin and then into bilirubin.
And this first bilirubin is lipid-soluble, right?
Right, so we call it unconjugated bilirubin. It needs a ride, so it travels through the blood, often bound to albumin, all the way to the liver.
And the liver's job is to make it water-soluble.
Exactly. It does that by conjugating it to glucuronides.
And the moment it's conjugated, it can be excreted.
Precisely. This new conjugated bilirubin is actively excreted via the bile, straight into the gut. And once it's in the intestines, the bacteria get to work.
They break it down further.
They reduce the conjugated bilirubin into a group of colorless compounds, mainly stercobilinogen and stercobilin.
And what's the clinical outcome of these breakdown products in the gut? Where do we see them?
Well, stercobilin is what gives feces their characteristic brown color. So that's the majority of it leaving the body.
Not all of it.
Not all of it. A small portion of that stercobilinogen is reabsorbed back into the circulation from the gut. This reabsorbed bit travels to the kidney, where it's converted into your urobilinogen and urobilin, or urochrome.
And that's what gives urine its yellow color.
That's the compound. So if you see elevated levels of urobilinogen in the urine, it's a direct quantitative measure reflecting an increased overall rate of hemoglobin breakdown.
That makes the path really clear. Iron gets recycled, protoporphyrin becomes stercobilin and urobilin.
What about the globin chains? Are they useful?
Oh, entirely useful. The globin chains are simply broken down, hydrolyzed into their constituent amino acids.
And they just go back into the general pool.
Exactly. They're fed back into the general protein synthesis pool for use all over the body.
Okay, before we leave the baseline, you mentioned normal destruction is almost entirely extravascular. But we do have a cleanup mechanism in the plasma, don't we? Haptoglobin.
Haptoglobin is essential. It functions primarily as an early warning or, a rapid response system.
So it's a scavenger.
It's a plasma protein designed to bind any free hemoglobin that might just inadvertently leak out of a red cell and into the plasma. It forms a hemoglobin-haptoglobin complex.
Which is then removed. And that complex is then efficiently removed by the RE system. This mechanism is so critical because in a normal, healthy state, intravascular hemolysis, the lysis of cells inside the blood vessels, should play little to no role. Haptoglobin is just there to clean up the tiny, normal margin of error.
So we know the healthy cell lasts 120 days. Now let's define the pathological state. What actually constitutes a hemolytic anemia?
Simply put, it's an anemia that results from an increased rate of red cell destruction. The red cell lifespan is shortened, often dramatically, from 120 days down to maybe 60, 40, or even just a few days.
And here is where we get to the body's truly incredible power of resilience. It's often surprising to people studying this for the first time, this concept of compensated hemolytic disease. You can have a patient who is actively destroying red cells at 3 or 4 times the normal rate, yet their hemoglobin levels are perfectly normal. How does the body pull off that miracle of compensation?
It's a spectacular feat of biological engineering by the bone marrow. The normal adult marrow is capable of increasing red cell production, what we call erythropoietic hyperplasia, by 6 to 8 times the normal rate.
6 to 8 times. That capacity is almost unbelievable.
It is, and this compensation is achieved not just by working harder, but sometimes by anatomical extension, where fatty marrow actually converts back into functional red marrow.
And the sign of this is reticulocytosis.
Exactly. This massive ramped-up production is why we see a marked reticulocytosis in the peripheral blood. These are the young, immature red cells, and their presence in high numbers is the clinical sign of this massive compensatory effort.
So if the marrow can produce cells 8 times faster than normal, that means anemia only becomes clinically apparent when the red cell lifespan drops below a certain critical point. What is that point?
Anemia typically only becomes clinically apparent when the lifespan drops below approximately 30 days.
So below 30 days.
Right. If the destruction is happening quickly, say the lifespan is 50 days, but the marrow can keep up, we call it compensated hemolytic disease.
The patient is hemolyzing, but they are not anemic.
Exactly. And that distinction is absolutely crucial for diagnosis.
Let's look at how we classify these disorders structurally. The primary distinction really helps us figure out where the investigative effort should focus.
We use a simple, pretty robust classification based on the location of the defect. So hereditary hemolytic anemias are almost always the result of an intrinsic red cell defect.
The cell is built with a flaw.
The cell is built with a flaw, a problem with the membrane structure, like in spherocytosis, or its internal metabolism, like G6PD deficiency, or the hemoglobin molecule itself, like sickle cell disease.
And the second larger group.
That would be the acquired hemolytic anemias. These are generally the result of an extracorpuscular or, an environmental assault.
So the cell is fine when it leaves the marrow.
The cell is perfectly normal when it leaves the marrow. But external forces, be it antibodies, physical trauma, toxins, or infections, attack and destroy it.
You mentioned there's one major exception to this intrinsic versus extrinsic rule, and that is a critical nugget to remember.
That is paroxysmal nocturnal hemoglobinuria, or PNH.
Yeah.
PNH is an acquired condition, but the defect that makes the cell susceptible to lysis, the lack of certain protective surface proteins, is intrinsic to the red cell lineage.
So it's acquired but intrinsic.
It's the single most important exception to this classification rule. You have to remember it.
Moving to the general clinical picture, if a patient is experiencing chronic hemolysis, regardless of the cause, what are the, say, 3 or 4 universal signs we look for?
First, naturally, is pallor if the patient is anemic. Second, and highly characteristic, is mild fluctuating jaundice.
And this is key. It's from the unconjugated bilirubin.
Specifically, it's caused by the massive overload of unconjugated bilirubin being produced by the increased red cell breakdown. The liver just cannot conjugate it all fast enough.
And because that bilirubin hasn't been conjugated and excreted efficiently, what does that mean when we check the urine?
This is a major diagnostic clue. Because the body is struggling with the unconjugated bilirubin overload, and only conjugated bilirubin is water-soluble and can pass into the urine, there is no bilirubin in the urine in extravascular hemolysis.
None. So if you see bilirubin in the urine,
You are looking at obstructive jaundice or liver disease, not simple extravascular hemolysis.
but the urine still looks dark, right? How do we explain that?
The urine is often dark, yes, but it's not due to bilirubin. It's due to the massive increase in breakdown products further down the pathway. That excess decobilinogen, which is reabsorbed from the gut, gets converted into urobilinogen and urobilin in the kidney.
So you get excess
You
urobilin.
get excess urobilin, or urochrome, which darkens the urine. The source notes that the urine might even look normal when it's passed, but it darkens on standing as the colorless urobilinogen oxidizes into the highly colored urobilin.
So dark urine plus jaundice, but no bilirubin in the urine, strongly points toward a hemolytic process, particularly extravascular.
Mm.
And what about the long-term complication caused by this chronic unconjugated bilirubin excess?
The most common long-term complication is the formation of pigment gallstones. Unconjugated bilirubin, being fat-soluble, just precipitates easily in the gallbladder.
And you can see this on imaging.
Our source material shows an ultrasound image, and you can frequently see these small bilirubin stones, especially in chronic conditions like hereditary spherocytosis. This often requires clinical management, maybe even a preemptive cholecystectomy later in life.
We also have those specific complications that can help narrow down the diagnosis, acting like little signposts.
Yes, definitely. For example, recurrent ankle ulcers are a common feature in sickle cell disease and also in severe hereditary spherocytosis.
And bone deformities.
Bone deformities can occur in massive, untreated marrow expansion, like in severe forms of thalassemia major, where the body is just desperately trying to make red cells.
And in acquired diseases.
Particularly those mediated by cold antibodies, patients can exhibit icral discoloration, this purplish mottling of the earlobes, fingertips, or nose, because the red cells are actually clumping together in those small, cooled peripheral vessels.
Finally, before we hit the labs, we have to cover the most dangerous acute complication, the aplastic crisis. This is where a stable chronic condition suddenly becomes life-threatening.
An aplastic crisis is a sudden, sharp, and severe worsening of anemia due to the temporary cessation of red cell production in the bone marrow.
The factory just shuts down.
It shuts down, and this is characterized by a rapid, profound drop in the reticulocyte count, the sign that the marrow has suddenly stopped responding.
What usually precipitates this catastrophic failure?
By far, the most common trigger is infection with parvovirus B19. Parvovirus has a specific tropism for it. It just destroys the erythroid precursors in the bone marrow.
And in a normal person, this doesn't really matter.
It's irrelevant because their red cells last 120 days. But in a hemolytic patient whose cells might only last 40 days, this shutdown means the existing red cell population rapidly decays without any replacement. The HB level just plummets in days.
Are there any other causes of aplastic crisis?
Less commonly, yes. Chronic severe hemolysis creates such a high demand for folate that it can deplete the body's reserves. That can lead to a folate deficiency-induced megaloblastic crisis, which also shuts down effective erythropoiesis.
But parvovirus is the main one to watch for.
Parvovirus is the primary concern, definitely.
Okay, let's get into the lab.
The laboratory investigation of hemolytic anemia is incredibly systematic, and the findings conveniently fall into three groups. It allows us to confirm the destruction, gauge the response, and then identify the damaged cells themselves.
Let's start with group 1, evidence of increased red cell breakdown. What are the three non-morphological markers that tell us hemolysis is ongoing?
We look at the breakdown products. First, the serum bilirubin is raised, specifically the unconjugated fraction. Second, as we discussed, the urine urobilinogen is increased, reflecting that increased gut metabolism. And third, and this is perhaps the most powerful indicator of significant ongoing hemolysis, is the status of the serum haptoglobins.
And what happens to haptoglobins during hemolysis?
They're absent or severely reduced.
Because they're all used up.
Exactly. Remember, haptoglobin is the plasma's scavenger for free hemoglobin. If red cells are being destroyed rapidly, haptoglobin is constantly saturated by the released hemoglobin, and the entire complex is rapidly cleared by the RE system. This leads to haptoglobin depletion.
So a low or absent haptoglobin is direct, powerful evidence.
It is, especially the intravascular type, even when the resulting anemia is mild or compensated.
Okay, moving to group 2. Evidence of increased red cell production, which confirms the body is trying to compensate.
This is the evidence of the ramped-up factory. Clinically, we look for marked reticulocytosis, the increase in young red cells. Microscopically, we look at the bone marrow itself, where we see erythroid hyperplasia.
And you quantify that with the M to E ratio?
Yes, the myeloid to erythroid ratio. Normally, that ratio is high, often ranging from 2 to 1 up to 12 to 1.
Meaning more white cell precursors than red?
Far more.
Yeah.
In hemolytic anemia, the red cell production line is so massively ramped up that this ratio is dramatically reduced, often down to 1 to 1, or sometimes even reversed. It just shows the dominance of the red cell precursor population.
And group 3, visualization of damaged red cells. This requires a sharp eye on the peripheral blood film.
This is where morphology is everything. You're looking for characteristic shapes like microspherocytes, these small, dense spheres or elliptocytes, or fragments, which we call schistocytes.
And beyond the blood film?
Beyond the simple blood film, you need specific tests to pinpoint the cause. This includes flow cytometry, specifically eosinomalamide, or EMA, staining, which measures membrane protein content, and then molecular tests like enzyme assays, protein electrophoresis, or DNA sequencing to confirm the exact underlying genetic defect.
Let's dedicate some serious time now to the dichotomy that defines the clinical findings. Intravascular versus extravascular hemolysis. This distinction really dictates what happens to all those breakdown products.
This is the single most important conceptual split in this chapter. In extravascular hemolysis, which is the mechanism for most chronic inherited disorders like HS and warm AIA, the destruction occurs within the macrophages of the RE system.
In the spleen, liver, and marrow.
Right. The hemoglobin breakdown products are handled locally by the macrophage before they're released into the circulation as unconjugated bilirubin. This is your classic jaundice, splenomegaly, absent haptoglobin profile.
But in intravascular hemolysis, the red cell explodes inside the blood vessel, dumping its contents directly into the plasma. This is a much more dramatic event.
It is an acute crisis. This lysis just saturates the haptoglobin mechanism instantly. With no available haptoglobin to bind it, this massive excess of free hemoglobin remains in the plasma.
And it's a small molecule.
It's a relatively small molecule, so this excess hemoglobin is then filtered rapidly by the glomerulus in the kidney.
And that filtration leads to the 3 specific laboratory hallmarks of intravascular hemolysis, which are visually and clinically striking.
First, we see hemoglobinemia-free hemoglobin in the plasma. Second, if the capacity of the renal tubules to reabsorb that filtered hemoglobin is exceeded, we get hemoglobinuria.
And the urine changes color.
The source material shows this really well with images of urine samples. The urine will be distinctly dark, red, brown, or even black. This is a medical emergency sign.
What is the third, slightly more chronic indicator of intravascular destruction?
That is hemosideruria. This is a fascinating sign of prolonged or repeated intravascular destruction. The hemoglobin that's filtered by the kidney is reabsorbed by the renal tubular cells.
Okay.
These cells break down the hemoglobin and store the iron as hemosiderin, which are these iron deposits. Over time, these tubular cells containing hemosiderin are shed into the urine sediment.
So you can stain for it.
We confirm this by performing a Prussian blue stain on the urine sediment. If it turns blue, you have positive hemosideruria. And this finding is crucial because it can persist for days or weeks after an acute event, acting as a historical marker of lysis.
And there's a fourth, less commonly measured marker as well.
Yes, methanobuminemia. When the volume of free hemoglobin just overwhelms the cleanup systems, the heme component can combine with plasma albumin to form methanalbumin, which you can detect spectrophotometrically, another sign of flooding.
So if we see those signs, hemoglobinuria and hemosideruria, we know the destruction is happening inside the plumbing. What are the major causes of the severe acute intravascular hemolysis?
The classic examples are highly destructive things like a mismatched blood transfusion, which is an immediate, severe immunological reaction, or fragmentation syndromes where cells are sliced mechanically.
G6PD crises.
Certain drug-induced G6PD deficiency crises with severe oxidant stress, paroxysmal nocturnal hemoglobinuria, PNH, and severe autoimmune hemolytic anemia where complement is fully fixed. All of these can cause it.
Okay, Now we launch into the specific diseases, starting with those intrinsic flaws, the hereditary hemolytic anemias. And we begin with membrane defects, the structural weak points. The most common is hereditary spherocytosis, or HS.
HS is the most frequent hereditary hemolytic anemia in Northern Europeans. And to understand it, you have to think of the red cell membrane like a tent. You have the lipid bilayer, which is the tent fabric, held up by this intricate internal scaffolding, which is the membrane skeleton.
And HS, what goes wrong?
The problem is a failure of the vertical interactions between that skeleton and the lipid bilayer. The structural anchors fail.
So the tent fabric is coming loose from the poles.
Exactly. The source material details this, noting that the cell literally loses parts of its membrane lipid bilayer as it tries to squeeze through tight spots, particularly in the splenic microcirculation.
And if the cell loses surface area but not volume, what is the resulting shape?
It minimizes its surface area by adopting the most energy-efficient shape, which is a perfect sphere, the spherocyte.
But spherocytes are terrible at their job.
Terrible. They're much less deformable than a normal biconcave disc. When they try to navigate the restrictive microcirculation of the spleen, they're recognized as non-viable, they get trapped, and they're prematurely destroyed by the splenic macrophages. The spleen is truly the villain here, the site of this massive extravascular destruction.
Let's drill down on the molecular basis. Which proteins are typically defective?
The underlying genetic defects cause problems with the assembly or function of key structural proteins. The most common defect, in about half of all cases, is an abnormality or deficiency in ankyrin,
Which is an anchor protein.
a critical anchor protein. Other common defects involve alpha or beta spectrin, which are essential scaffolding components, or protein band 3 or pallidin, also called protein 4.2. Regardless of the specific protein, the net result is always the same: failure of vertical stability and subsequent membrane loss.
Clinically, outside the general features of hemolysis, what stands out for the HS patient?
They often have mild fluctuating jaundice. Splenomegaly is present in the majority of patients, reflecting its hyperactive role. And as we mentioned, the risk of pigment gallstones is extremely high. And you always have to be worried about that parvovirus-induced aplastic crisis.
In the lab, the microspherocytes on the blood film are the immediate giveaway. These cells lack that central pallor we expect to see. How is the diagnosis confirmed today?
Historically, we relied on the osmotic fragility test, which showed that spherocytes burst easily in dilute saline because they had less surface area to accommodate swelling. But the modern gold standard method is a rapid flow cytometric analysis using eosinmalamide or EMA staining.
What does the EMA staining actually measure?
EMA is a fluorescent dye that specifically binds to the band 3 protein on the red cell membrane. In HS, because of the underlying membrane protein defects, even if the defect isn't band 3 itself, the cell's capacity to bind EMA is reduced.
So you see a lower fluorescence.
You see a lower mean channel fluorescence compared to normal cells. This test is quicker, it's more specific, and it's replaced the older, less reproducible osmotic fragility test.
And the necessary exclusionary step.
Yeah.
Because other things cause spherocytes.
Absolutely. Microspherocytes are also the hallmark of warm autoimmune hemolytic anemia, so we must confirm that the direct antiglobulin test, the DT or Coombs test, is normal. If the DT is positive, the spherocytosis is likely acquired and immune-mediated, not inherited.
Regarding management, since the spleen is the major culprit, the solution often involves surgery.
Splenectomy is the definitive treatment for symptomatic HS because it removes the main filter that is destroying the cells. But it is a risk-benefit decision. The operation is typically reserved only for patients who are clinically indicated.
So those with symptomatic anemia, gallstones, leg ulcers.
Or growth retardation, yes. The risk is lifelong post-splenectomy sepsis, which is why it's avoided in very young children if possible.
And the outcome is critical to understand. Does splenectomy cure the membrane defect?
Absolutely not. The red cells still have the same flawed membrane. Even after a successful surgery, microspherocytes will persist in the circulation. But the main site of premature destruction is gone, so the hemoglobin level typically normalizes and the patient feels cured.
And you give them folic acid?
Folic acid supplementation is essential in severe cases to support the consistently high red cell turnover.
Okay, moving on to the related but generally milder condition, hereditary elliptocytosis, or HE.
Right. If HS is a failure of the vertical anchors, HE is often a failure of the horizontal interactions of the membrane skeleton. This is usually caused by spectrin mutants that prevent proper spectrin dimer formation.
And the cells become elliptical.
They assume a characteristic elliptical or cigar shape, But because this shape doesn't necessarily impair deformability severely, the hemolysis is usually mild. It's often discovered incidentally.
But there is a very severe specific variant to highlight.
That is hereditary pyrrhopoikilocytosis, HPP. It's most common in people of African descent and presents as a severe, life-threatening hemolytic anemia, often requiring splenectomy early in life. These cells are particularly prone to fragmentation and extreme shape distortion, especially when you heat them, which is where the name pyrrhopoikilocytosis comes from.
The source also points out a couple of fascinating, rarer membrane defects, hereditary stomatocytosis, for example.
That's a rare condition where there's a defect in membrane permeability, often causing a cation leak of sodium and potassium. The resulting red cells have this characteristic morphology on the blood film, a mouth-like slit of central pallor. That's the stomatocyte.
And the evolutionary nugget of Southeast Asian ovulocytosis.
This is a perfect example of natural selection. It's highly prevalent in areas endemic for malaria and is caused by a 9-amino acid deletion in the BAM3 protein. This defect makes the cells rigid and oval.
And that rigidity protects against malaria.
Crucially, this rigidity provides resistance against invasion by Plasmodium falciparum malaria parasites. Most affected individuals are asymptomatic for the hemolysis itself, showing that evolutionary benefit can trump minor physiological flaws.
We've covered structural failure. Now let's look at engine failure, the metabolic defects. These link complex internal biochemistry directly to the cell's ability to survive. And the single most important one globally is glucose-6-phosphate dehydrogenase, or G6PD deficiency.
G6PD deficiency is all about the red cell's defense system against its greatest enemy, oxidative stress.
Lay out the mechanism for us.
So G6PD is the rate-limiting enzyme in the pentose phosphate pathway. Its function is to reduce NADP into its reduced form, NADPH. And this step is non-negotiable, as G6PD provides the only source of NADPH in the red cell.
And why is NADPH so vital?
NADPH is essential for maintaining the level of reduced glutathione, or GSH. And GSH is the cell's crucial internal antioxidant defense. If GSH levels drop, the cell loses its ability to protect its hemoglobin and its membrane from a highly reactive oxygen species.
So the whole defensive shield collapses.
It collapses, leaving the cell nakedly susceptible to damage.
The epidemiology here is vast, covering hundreds of millions of people worldwide. How is it inherited, and where do we see it?
It is the most widespread enzyme deficiency globally, affecting over 400 million people. It's a sex-linked inheritance, meaning males are primarily affected while females are carriers. And its distribution, as shown in the notes, perfectly mirrors areas that are endemic for falciparum malaria.
Which brings us back to that evolutionary advantage.
Indeed, female heterozygotes, and to a lesser extent affected males, possess a degree of resistance against falciparum malaria. This selective pressure is why the gene is so prevalent.
You mentioned severity varies dramatically. What are the key variants?
Yes, the deficiency is classified by its residual enzyme activity. In people of Black African descent, the type A variant is common. This is relatively mild, retaining 10 to 60% of normal activity.
That's the Mediterranean type.
In contrast, the Mediterranean or Middle Eastern variants are type Mediterranean, and they are much more severe, often retaining less than 10% activity. And this difference in severity dictates how life-threatening an acute crisis can be.
Crucially, G6PD deficient patients are typically asymptomatic until they encounter a trigger. What defines the list of oxidant stressors they must avoid?
The main syndrome is an acute, sudden hemolytic anemia precipitated by oxidant stress. The triggers fall into three main categories: drugs like the anti-malarial Primacan or various sulfonamides, severe infections, and the ingestion of fava beans.
Fava beans, which contain potent oxidants.
Yes, vicine and divicine.
When triggered, what type of hemolysis defines a G6PD crisis?
Because the damage is so rapid and diffuse, it results in severe intravascular hemolysis with hemoglobinuria. The red cell membrane just suddenly suffers irreversible damage.
Can it be self-limiting?
It can be in the milder forms, as the older, most deficient cells are realized, leaving the younger reticulocytes with higher enzyme levels to survive. But in severe types, it is absolutely life-threatening.
Let's look at the blood film during a crisis. What evidence do we have of this oxidative damage?
The blood film is fascinating. We see fragmented red cells and two specific morphological signs: bite cells and blister cells. And these are formed when the spleen's macrophages attempt to surgically remove Heinz bodies.
What exactly are Heinz bodies?
They are precipitated, oxidized, and denatured hemoglobin that is clustered against the interior of the red cell membrane because the GSH defense system failed.
So the macrophage tries to clean it up?
The splenic macrophages, attempting to clean up the damaged cell, literally nibble out the segment of the membrane containing the Heinz body. And this removal creates that characteristic concave margin, the bite cell.
Now, you mentioned a critical diagnostic trap for the enzyme assay. If a patient is acutely hemolyzing, the test might mislead us.
This is a point that absolutely must be remembered. Because the crisis selectively destroys the oldest and most deficient red cells, the remaining circulating population is disproportionately young. It's dominated by reticulocytes.
Which have higher enzyme activity.
Exactly. Reticulocytes naturally have higher G6PD enzyme activity. So if you perform the enzyme assay during the acute crisis, the result can be falsely normal or near normal.
So you have to wait.
You must wait and reassay the patient after the acute phase has fully passed, when the red cell population has normalized its age distribution, to confirm the underlying chronic deficiency.
Treatment then hinges entirely on managing the acute event.
That's right. First step is immediate. Remove the offending drug or treat the underlying infection. Since you're dealing with severe intravascular lysis, it is vital to maintain a high urine output to prevent the free hemoglobin from causing acute renal injury. Blood transfusion is reserved for patients with severe, life-threatening anemia.
The second major hereditary metabolic defect involves the energy source itself, the glycolytic pathway, specifically pyruvate kinase deficiency.
Pyruvate kinase, or PK, deficiency is the most common inherited defect in the pathway that generates the majority of the red cell's ATP. It's autosomal recessive. PK is essential for generating ATP, and if ATP production drops, the ion pumps fail, leading to red cell dehydration and rigidity.
So similar to HS, the cells become rigid, get trapped, and are destroyed in the RE system. But the cause is biochemical failure, not structural failure.
Precisely. The severity of the anemia is highly variable. What's unique about PK deficiency is that patients are often surprisingly well compensated, even with very low baseline hemoglobin levels.
And that compensation mechanism is due to another enzyme product, 2,3-DPG, right?
Yes, because of the block in the lower glycolytic pathway, there is a compensatory increase in 2,3-diphosphoglycerate, or 2,3-DPG.
And that shifts the oxygen dissociation curve.
It shifts the curve to the right, meaning that the hemoglobin releases oxygen to the tissues much more easily. So the patient's tissues remain adequately oxygenated, masking the severity of the anemia.
Clinically, what do we see?
Chronic jaundice and a high frequency of pigment gallstones. The blood film might show reticulocytosis and characteristic distorted prickle cells, particularly after splenectomy.
How is the diagnosis made, and what are the management challenges?
Diagnosis requires a direct enzyme assay. Splenectomy may alleviate the anemia, but it is not a cure. The major long-term management challenge is the high risk of iron loading, caused both by transfusions and the ineffective red cell production itself. That requires careful monitoring and chelation therapy.
And new therapies are emerging here.
Yes, our source material highlights this, specifically mentioning a small molecule activator of pyruvate kinase, AG348, which is showing promise in clinical trials. This signals a shift toward fixing the intrinsic defect rather than just managing the destruction site.
We shift now from intrinsic structural failure to extrinsic environmental attack. The most important acquired causes are the autoimmune hemolytic anemias, or AIHA, where the immune system targets its own red cells. This is a battle against the self.
And the definition of AIH rests entirely on one test, a positive, direct antiglobulin test, or DA, the Coombs test.
And a positive D8 confirms antibodies or complement are on the red cell surface.
Yes, and we classify AIA based on the type of antibody and its thermal optimum, warm or cold.
Let's start with the most common form, warm autoimmune HA, mediated primarily by IDJ.
Warm AIA is defined by IgG autoantibodies that react optimally at body temperature, 37 degrees Celsius. These IgG molecules coat the red cells, and they act as eat-me signals.
Signals for the macrophages.
They're recognized by the F10C receptors on the RE macrophages, predominantly in the spleen.
Describe the process of destruction at the splenic level. Is it total engulfment?
Not necessarily. The macrophage binds the Ig-coated red cell, but often it literally nibbles off portions of the red cell membrane to remove the segment containing the antibody.
So it creates spherocytes again.
This progressive membrane loss, without a volume loss, results in the formation of microspherocytes, and these microspherocytes are then less deformable, they get trapped, and they're finally destroyed prematurely in the spleen, making this primarily an extravascular process.
WAA often follows a course of remission and relapse, and we need to investigate what might be driving the immune system to act this way.
Absolutely. While it can be idiopathic, it is often secondary to underlying conditions. We must always investigate for associated lymphoid malignancies like CLL or lymphoma or other autoimmune disorders like SLE.
So a full workup is needed.
A thorough search, typically including a CT scan, is standard to rule out an underlying lymphoproliferative disorder. And we also see Evans syndrome, which is AIHA plus ITP immune attack on both red cells and platelets.
Lab findings show the classic extravascular profile, high spherocytosis. What does the DAT show specifically in YHA?
The DAT is positive for IgG alone or sometimes Ig plus complement.
And treatment requires a highly structured, step-by-step strategy. Was the crucial first line of defense?
If a drug or underlying condition is found, removing or treating it is the priority. But the immediate first-line treatment for the hemolysis itself is corticosteroids, typically high-dose prednisolone.
How do steroids work here?
They work by suppressing the production of the autoantibody and, crucially, by blocking the FMC receptor function of the splenic macrophages, reducing their destructive nibbling action.
But the source notes steroids aren't universally effective.
They are not. Patients whose red cells are predominantly coated with complement tend to respond poorly to steroids, and we have to be vigilant about the side effects of prolonged steroid use, so we need bone protection, vitamin D, calcium, and bisphosphonates.
What happens when the patient is steroid refractory?
We escalate therapy. Second line, which is increasingly used earlier, is the monoclonal antibody rituximab. Rituximab targets CD20 on B lymphocytes, thereby suppressing the production of the autoantibodies themselves.
And if that fails?
Then splenectomy is considered. Since the spleen is the major site of destruction, removing it often works well. But it's reserved for patients who fail to respond or can't maintain a stable hemoglobin on a low dose of steroids. After that, you're looking at other immunosuppressants like azathioprine.
Now let's talk about the absolute nightmare scenario for the blood bank. Transfusing a YEA patient.
It is extremely difficult. It requires specialized expertise. The patient's autoantibody coats all red cells, making standard cross-matching impossible.
Everything reacts.
The patient's serum reacts with virtually every donor unit you test. The blood bank has to identify the least incompatible unit, often relying on phenotyping, to try and match known common blood group antigens.
And there's a risk of creating new problems.
Yes. These patients have a propensity to develop alone antibodies against donor red cell antigens. They're hyperreactive, so careful matching is crucial. And venous thrombosis prophylaxis is usually indicated because the whole process is very prothrombotic.
Let's contrast that highly inflammatory warm disease with cold autoimmune HA mediated by IgM.
Cold AIHA is all about temperature dependence. The IgM autoantibody binds efficiently to red cells, primarily in the peripheral circulation where the blood temperature drops.
So in the fingers, toes, ears?
Exactly. And IgM is a massive molecule, highly efficient at fixing complement. This leads to both intravascular lysis, when complement goes to completion, and extravascular destruction.
What is the clinical origin of these cold antibodies?
They can be transient and polyclonal, often following infections like mycoplasma pneumonia or infectious mononucleosis, or they can be monoclonal, associated with primary cold agglutinin syndrome or an underlying lymphoproliferative disorder.
And the symptoms are directly linked to the temperature.
They are. Patients have chronic hemolytic anemia, sharply aggravated by cold. They may suffer from acrocyanosis, that purplish discoloration of cold-exposed areas, caused by the physical agglutination of their red cells inside those small peripheral capillaries.
Now, the DAT result here is the key diagnostic separator from YI. What does the DAT show?
The DAT shows complement, C3 only. This is a major insight into the mechanism. The IgM binds in the cold periphery, it fixes complement, but then, as the blood returns to the warmer central circulation,
It falls off.
the IgM molecule elutes off the red cell surface, but the fixed complement fragments, the C3, remain stubbornly attached. So the C3 finding is the smoking gun, proving the IgM was there, even though the antibody itself is gone.
Since this is often linked to a B-cell or lymphoproliferative process, how does the treatment differ from YU high?
The absolute priority is to keep the patient warm to prevent the antibody from binding. Pharmacologically, rituximab is the best first-line therapy, sometimes combined with drugs like fludarabine or bendamustine as we're treating the underlying clone producing the antibody.
So steroids and splenectomy don't work as well?
Generally less effective in CI high because the primary site of destruction is less localized to the spleen and the pathology is driven by the complement cascade. The source also mentions newer, promising but expensive complement inhibitors like eculizumab or sudlimab, which specifically block that cascade.
And let's quickly note the rare but dramatic paroxysmal cold hemoglobinuria, PCH.
PCH is distinct from CIH. It's an acute episode of massive intravascular lysis after cold exposure. It's caused by the unique Doneth-Lansdyner antibody,
Which is an IgG.
an IgG, unusually, with specificity for the P blood group antigen. Its action is biphasic. It binds to the red cell in the cold, but it only activates complement and causes lysis when the temperature returns to warm. It's usually self-limiting, often related to a viral infection.
Finally, for immune types, drug-induced immune HA, which has 3 complex mechanisms.
Right. It looks like AIHA, but it resolves when the drug is stopped. The 3 mechanisms are, 1, the Hampton mechanism, where an antibody forms against the drug red cell complex, like with high-dose penicillin.
Here.
The immune complex mechanism. A drug-protein antibody complex forms in the plasma and then non-specifically deposits complement on the red cell.
And 3.
A true autoimmune response, where the drug somehow induces a real AIH that resolves when the drug is discontinued. The key for all 3 is stop the drug.
Our final major category involves destruction caused by mechanical forces, toxins, or infections. The red cell fragmentation syndromes. This is pure physical trauma.
It is. And it happens when the cell is forced across an abnormal surface. This could be a man-made surface, like a prosthetic heart valve, especially an older mechanical one, or an arterial graft.
But the most significant form is MAA.
Yes, microangiopathic hemolytic anemia, or MAHA. This is where red cells are violently damaged as they are forced through small vessels that have been obstructed or narrowed.
And the source material uses a great analogy for this.
Imagine the vessel lumen stretched tight by high-tension fibrin strands, like a cheese cutter stretched across the vessel. As the red cell slams into those fibrin strands, which you see in DIC, or as they pass over damaged endothelium with excessive platelet adherence, like in TDP, the cells are just sliced apart.
And the resulting pieces are called schistocytes.
Yes, the peripheral blood film contains numerous deeply staining red cell fragments, or schistocytes. If the MAHA is related to DIC, you'll also see clotting abnormalities and low platelets.
We should also mention March hemoglobinuria, a specific form of mechanical damage.
A classic example. It occurs in marathon runners or soldiers who march long distances. The red cells are physically crushed by impact between the small bones of the feet. This causes acute intravascular hemolysis and transient hemoglobinuria. But crucially, because the lysis is instant and not from fibrin mesh, the blood film does not show fragments.
Beyond mechanical slicing, infections are a large extrinsic driver of hemolysis.
They are. They can precipitate crises, like we saw with G6PD. They can cause MAHA, like with severe meningococcal septicemia.
And the major infectious cause worldwide is malaria.
Malaria is a huge hemolytic culprit. The parasite invades the red cell, and you get both extravascular removal of parasitized cells by the spleen and, in severe cases, direct intravascular lysis.
And the most dangerous complication of falciparum infection.
Black water fever. This is acute, massive intravascular hemolysis that results in acute renal failure from the overwhelming hemoglobin load, a life-threatening complication. We also see hemolysis caused by toxins from Clostridium perfringens, septicemia, and tick-borne illnesses like babesiosis.
Finally, let's cover the general external chemical and physical agents.
High doses of certain drugs, even in people with normal G6PD, can cause oxidative hemolysis, and Heinz body formation dapsone and sulfasalazine are good examples.
And toxic exposures.
Severe hemolysis can occur with high copper levels, like in Wilson disease, or poisoning from industrial chemicals like lead, chlorate, or arsine. And physical agents, like severe burns, directly damage the red cell membrane, leading to bizarre shapes.
And we end with the final category, secondary hemolytic anemias.
These are generalized systemic disorders, inflammatory bowel disease, chronic liver disease, where the underlying chronic inflammation causes a modest but measurable shortening of the red cell lifespan. It contributes to the overall anemia of chronic disease.
We have completed a comprehensive tour of the red cell's premature demise, from inherited flaws to violent external attacks. Let's distill this down to the core conceptual takeaways you need to hold on to.
Remember the fundamental diagnostic dichotomy. Hemolytic anemia is simply a shortened red cell life. And the most powerful way to analyze the patient's presentation is to distinguish between the location of destruction.
If the destruction is extravascular, the spleen and RE system are the culprits. This means prominent splenomegaly, jaundice, absent haptoglobin, and often the formation of, and structurally keep the intrinsic versus extrinsic defects clear. Inherited defects are intrinsic, the cell is built wrong. Acquired causes are extrinsic, and outside force is attacking a normal cell. And the direct antiglobulin test, the DAE, remains the most crucial tool for separating AIA from intrinsic defects like HS, where the DAT is normal.
One final thought to contemplate as you process this material. Consider the sheer mechanical challenge of the spleen. The red cell membrane is a miracle of stability, yet it must withstand 120 days of brutal high-velocity circulation. When we treat severe hereditary membrane defects, the medical intervention often isn't fixing the underlying molecular flaw, it's simply removing the spleen.
Removing the spleen allows those structurally imperfect cells to survive longer. What does this tell us about the crucial, almost impossible role the spleen plays as an unforgiving physical filter? It mercilessly exposes even the slightest structural imperfection. The spleen is the ultimate quality control mechanism, and removing it often forces the body to accept a lower quality of oxygen carrier. It underlines that sometimes the cure involves eliminating the body's own hyper-efficient filter.
A fantastic deep dive today. Thank you for joining us for this essential discussion on hemolytic anemias.